Meningioma is a group of rather slow-growing tumors, and they are derived from the meningeal layers of the arachnoid cells within the skull. And here we can see a tumor located. Do you see my marker? No. Do you see my marker here?
Yeah, Prof, so
yeah,
we can see your cursor, yeah.
Yeah. So here's the tumor, and it's compressing the brain. It is a rather common tumor, and about 30% of all the intracranial tumors are meningiomas, and they are more common in females than in males. It's a tumor that is more common in the elderly, and is very rare in children. And when it occurs in children, it's more aggressive ones. These tumors have well-defined localizations within the skull. It can be at the skull base, or at the midline, or at the convexities. It can also be located in the spinal, along the spinal cord, and it's very rare extracranially. Higher malignancy grades can metastasize. So these tumors are very slow growing. They can give no symptoms at all, only found on autopsies, or they can give neurological signs and symptoms due to compression of the underlying brain structures. And of course, due to the increased intracranial pressure, it can give you headache and seizures. Looking at MRIs, it's a very well-defined tumor with clear-cut margin to the brain, and it compressed the brain, and we also found a kind of dural tail, very typical for these tumors. The main treatment option for these tumors are surgery. If the situation is well or under control, the patient can be observed or wait and see. And the main treatment is surgery, and I try to get a gross resection, but in some cases only subtotal resection is possible. Even though this is a benign tumor, there are many complications during the operations. Hemorrhages is not uncommon, and even today people die at the operation theater due to hemorrhages. Also infections and brain infarctions, and also postoperative leakage of cerebrospinal fluid is common. In some cases, it's also indicated to use radiation therapy, various techniques for that, and can be used, for example, for high-grade tumors, when the tumor is inoperated or not radical removed, and also in older patients, for example, when there are medical contradictions. And then we have the problem with radiation injury, for example, with development of cognitive defects. Chemotherapy is today not very relevant, it's only at the experimental stage. Regarding pathology, here we have a gross picture of this tumor. It's attached to the skull, to the dura, one of the solid layers around the brain. Here we have the brain, and here we have the compression of the underlying brain tissue. Regarding histopathology, these tumors have many microscopical appearances, but here is a typical picture with whorls and also some calcified deposit called mama bodies. But it can look cystic, it can be more epithelioid, or look like a high-grade tumor with necrosis, as well as many small cells and many mitosis. So due to this heterogeneity of the microscopy findings, these tumors have many differential diagnoses under the microscope. Then there has been many revisions of the WHO classification system, and the last one given in 2016 divided these tumors based on histopathology and prognosis into 3 major tumor grades: grade 1, grade 2, and grade 3. Grade 1 is most typical, and is based, and there are very few what we call atypical features, and there are some subtypes also belonging to these grade 1, and these tumors have very good prognosis, and also with very few recurrences. But even though the histology is benign, up to 25% of these tumors will recur, so that's a problem. Grade 2 is about 20 to 30%. This is a little low number. They have a typical feature, like, for example, meningiomas and also necrosis, for example, and these have a much higher recurrence rate. But as you see here, about 50% of these tumors will not recur. Grade 3 is a highly malignant tumor, very uncommon. All these grading of these tumors is based on a pathologist's subjective assessment of what you see in the microscope. That means that the diagnosis is based on the experience of the pathologist, and that gives a problematic inter-observer variation. So there is a high need for more objective criteria that can identify patients that have an increased risk of recurrence. So here is some challenges we deal with today. There is a suboptimal classification because it's based on what you see in the microscope. There is a subjective assessment, not objective biomarkers. So the follow-up of these tumors is based on what was found in the microscope. And this is based on, there are many differential diagnoses. And as there is no optimal stratification of these tumors, therefore it's a problem to identify those patients that have an increased risk for recurrence. That also means that every patient do not go optimal follow-up. It also means that patient get under and over treatment. And if, for example, there is over treatment, this patient can suffer from diverse complications. So the goals for the meningioma treatment today is what can be put into the topic personalized medicine. That means we need a better system to get more accurate prognosis and diagnosis. That means that we can offer the patient a more optimal treatment and follow-up. And we can also operate the patient at an earlier stage, and then the complication will be reduced. And if you have a personalized medicine, the patient will get the medicine they need, and that is also beneficial for the health economics. Today, there are some established poor prognostic factors. That means some subtypes are associated with poor prognosis. Also, higher malignancy grade 2 and 3, is associated with higher degree of recurrence as well as overall death. High proliferative index, for example, high Ki67 index. Also, incomplete resected tumors will recur. Large tumor have a poor prognosis than small one. Also, some molecular pathology findings are associated with poor prognosis. It's recently established that, for example, some methylation subclasses are associated with poor prognosis, as well as various mutations, especially TERT mutations. In this setting, there are also need for objective markers to improve the diagnosis of these tumors. And in that regard, growth factors and their receptors are potential candidates. And very known pathologist from Germany, Christian Maurin, has in one of his books said that nearly all of the growth factor receptors or kinases known to be involved in tumor growth have been described to be expressed in meningiomas. So in that regard, we have looked at the members of the EGFR receptor family, also called erbB receptor proteins. These are 4 receptors. They are all plasmamembrane receptors with an external domain, a transmembrane domain, and an intracellular domain. And many of these receptors can bind various ligands, And when these receptors are activated, we have autophosphorylation of the internal domain that will activate a cascade of enzymatic pathways into the nucleus and will give various cellular effects such as proliferation, increased cell survival, as well as invasion and increased metastatic potential, as well as induce angiogenesis. These can be used, these findings, the increased expression of these receptor proteins can be used in various manners in clinical medicine. For example, if you have mutated proteins, it can be used, for example, for detection. You can also link various immunotoxins to these receptors used to target these neoplastic cells and kill them, as well as you can identify these tumors by attach some radionuclides and so on. So this is a practical use of these receptor proteins. So the main aim of this talk is to assess the diagnostic and prognostic value of EGFR family in this tumor. And this talk is based on a summary on one of my research fellows that defended his thesis recently, and the papers was here 3 publications on which this talk is made. We investigated a 10-year material of human meningioma that was consecutively treated at our hospital, and we ended up with more than 200 cases. Some cases were excluded. We just looked at adult patients. We just looked at intracranial tumors, not recurrent tumors. And we ended up with about 185 cases that were included in our studies. We ended up with then 129 benign and 56 atypical. We dropped the malignant one because there were so few. We have a very long observation time. This is very long, and we made a tissue microarray like you see here. Here's a tissue block. Here we have the cures taken out, put into the recipient block, and here we have the routine stain of the tumors. And here we have a liver just to make it for orientation of the tissue block. We use standard immunohistochemistry with a Dako autostainer, and we used various antibodies against the internal and external domain of EGFR, as well as the phosphorylated receptor. We also looked at the Severre or HER2 receptor, also against the external, internal, and phosphorylated domains, and also the internal domains of HER3 and 4. All were monoclonal antibodies. And we have relevant controls. In the negative controls, the antibodies were omitted, and we also included some normal meninges to evaluate this expression. And now some pictures of our immunostaining. Here we have a very strong and widespread immunoreactivity using an antibody against the internal domain of the EGFR. But many of the antibodies against the external domains, as well as the phosphorylated domains, were weaker, as we can see here. There's a faint staining. Regarding Severre, we have also found a strong plasmatic staining of the tumor cell. Compared, for example, to breast cancer, we found a typical cytoplasmatic staining, for example, but in breast cancer, it shall be a very clear membranous staining. So this is very different from that in breast cancer. As you can see here, the phosphorylated immunostaining was also weak. Regarding Severre or HER3 and erbB4 and HER4, there was a strong immunostaining in all the tumors. And the staining was located both to the cytoplasm as well as to the cell membrane. So here a summary of the finding. All cases were positive for all the antibodies against EGFR receptor. Related to tumor grade, only the phosphorylated receptor was associated with statistical significance, but only in univariate analysis. Regarding risk of recurrence, only the external domain was associated with this tendency, but also this was in univariate analysis. Regarding erbB, we found that all were positive for the internal domain, whereas the external domain, about 50% were positive and 10% positive for the activated receptor. And here, the activated receptor, it was in multivariate analysis, it was associated with multivariate. It was associated with recurrence. Regarding HER3 and HER4, no association was associated with tumor grade or recurrence. So then discuss these findings. We found that all the receptor proteins were expressed in this tumor, and it was a relative overexpression, as we did not find any immunoactivity in the normal meninges. So that means that these receptor protein can be used as a diagnostic markers in the daily routine in our pathology labs. However, there is a problem because there are other brain tumors or intracranial tumors that are positive as well. For example, glioblastoma can be positive for EGFR, and breast cancer can be positive for here too. So it's not a specific for meningioma. That all the receptors are currently expressed means that we have a facilitation of their dimerization, and that means after dimerization, then they be activated and can have the cellular effects on the tumor. There are, in general, a relative poor relation to tumor grade, so one can discuss that these receptor proteins are more involved in the tumor development and not to tumor progression. We experience some weaker intensity of the external domains. That is an experience we have done for many years. We have no obvious reasons for that. Perhaps the external domains are more fragile to tissue processing, for example. So in my hands, antibodies against the cytoplasmic domains are more robust than the external one. We found that there was a high expression of the phosphorylated receptor, and that can be a consequence of increased level of the ligands for this receptor. We have found that in 2 studies. So that can be a consequence of that. So this receptor can be continuously active. Regarding prognosis, only the phosphorylated erbB was associated with prognosis in our multivariate analysis. We are a little bit cautious to recommend these as a prognostic marker because the immunostaining was weak, and I think it have to study that further on. Where the other was only positive in univariate analysis, and as such not so promising candidates. So to sum up then, we found that all the receptor members of EGFR family were expressed in our series of meningiomas. In general, there are limited significance related to tumor grade and prognosis. However, this widespread expression can be used in various targeted clinical medical approaches. But the problem here is that other brain tumors are immunoreactive as well. So then that was my talk. Thank you very much for listening to my talk. I wish you a good day and good luck with the Congress. Here's a picture of our cathedral, the biggest one in Northern Europe, and now also with coming autumn colors on the trees. So have a nice day. Thank you for listening to me.